So typically the antibodies against acetylcholine receptor are IgG1 and IgG3. And those for musk myasthenia are typically IgG4. And so this is going to be a little bit important coming up in just a few. All right, so I just wanted to review what kinds of things precipitate a myasthenic crisis. So we have anything from infection, tapering of the immunosuppression that the patient might already be on, surgery, pregnancy, certain medications, and then sometimes apparently no cause. So in these medications, we want to think about antibiotics that we prescribe: quinine, magnesium, procainamide, beta blockers, and calcium channel blockers. Sometimes even the initial doses of prednisone can make myasthenia worse. And we want to make sure that we avoid Botox and neuromuscular blockers completely, as these can cause permanent sort of end plate conduction deficit. So the pathophysiology of acetylcholine receptor positive myasthenia. And moving forward, I might just say receptor positive myasthenia to summarize that. So acetylcholine antibodies are thought to disrupt the neuromuscular junction by several mechanisms. One of them is activation of complement, which results in the lysis of the receptor at the muscle end plate. The second is an antogenic modulation, which accelerates the internalization and degradation of these acetylcholine receptors. And then the last one is direct binding of the antibody to the receptor, which prevents the channel from opening. Overall, this causes a reduction in the neuromuscular transmission safety factor, which results in the symptoms that we see of myasthenia. So the thymus plays a pretty integral part in the pathogenesis of myasthenia. Thymomas occur about 10 to 15% of myasthenic patients, and thymic hyperplasia is even more common in those with receptor positive myasthenia. Some studies have shown that the receptor positive myasthenics have thymic hyperplasia. With thymic hyperplasia, their thymic tissue was highly active with increased numbers of B cells. They had epithelial cells that expressed these receptors. They had increased pro-inflammatory and cytokine production. And then they also had these antibodies against acetylcholine receptor. So those with thymoma also had a very similar pathologic footprint. But it's important to remember that the thymus isn't the only generator of acetylcholine receptor antibodies, because we found that in 30% of patients that don't have thymic hyperplasia, and then some patients who have undergone thymectomy and noticed clinical improvement, these patients are still found to have detectable levels of antibody in their serum. So it's speculated that antibody producing B cells in the peripheral circulation, in the lymph nodes, and even in the bone marrow have some role in the production of these antibodies. All right, so we'll just dive right into the current therapies, which I'm sure you all are familiar with. The therapies are broadly divided into 4 categories. So there's symptomatic treatment, which usually is the first line and usually includes pyridostigmine. There are maintenance therapies that are steroids or steroid-sparing agents. There are rapid short-acting therapies that are used in a more acute setting like exacerbation or crises. And then there's thymectomy, which is indicated in about 5 to 10% of patients that have a thymoma. And sometimes it's also indicated in patients that don't have a thymoma, but have the antibody receptor positive antibody profile and are under the age of 60 and have low risk factors. So pyridostigmine, you're all aware, is also called Mestinon, is a cholinesterase inhibitor, which affects the hydrolysis of acetylcholine. So this prolongs the effects of acetylcholine at the neuromuscular junction. It's rather fast acting, within 15 to 30 minutes, and peaks at about 2 hours. It results in sort of variable improvement in strength, so not all of our patients tend to improve. And then the dosing is slowly titrated up to 120 milligrams every 4 hours, but we can stop it at a dose where we see a good therapeutic effect. And then the side effects tend to be the typical cholinergic side effects of cramping and diarrhea, increased secretion, sweating. In the acute therapies, we typically use IVIG and Plex, and these are used in urgent situations like the crises, even in preoperative stages before a thymectomy. And then sometimes these are used to bridge into slower acting long-term immunosuppressive therapies. These tend to have a short onset of action of about 3 to 10 days, and then brief benefits that can last up to weeks. So PLEX involves removal of pathogenic antibodies and other plasma components. Typically, we do 5 exchanges over a course of 10 to 14 days. And this depletes the amount of immunoglobulin levels pretty rapidly, but it's important to remember that this is likely to rebound if there's no prolonged immunosuppression that started. One of the obvious disadvantages is having to place the catheter and all of the complications that come from that. And then we have IVIG that has many proposed mechanisms, but is used in the same scenarios, and it's a little bit more readily started. We start dosing at 2 grams per kilogram and given over 2 to 5 days. And the side effects here are mostly headaches, thrombotic events, heart failure, renal failure. Then we have these maintenance therapies, which the goal of these treatments is to provide prolonged immunosuppression. So the first of these is going to be prednisone, which is fast acting and typically used in the initial time of diagnosis. And its effects are pretty much evident within 2 to 3 weeks. But in the long term, the limitation is the many side effects that come from that. Then we have azathioprine, which requires anywhere from 6 to 12 weeks to become effective. 6 to 12 months to become effective. And the side effects here include leukopenia, hepatotoxicity, the flu-like reaction, and then even with long-term use, you might have leukemia or lymphoma that may develop. Then we have mycophenolate mofetil or Cellcept, which can take anywhere from 3 to 12 months to become effective, but its maximum effect may take anywhere from 1 to 2 years. And the side effects here are leukopenia and GI-related symptoms. And then we also have other therapies like cyclosporin and tacrolimus, which can take 6 months to become effective, but these aren't very commonly used in myasthenia. And I just want to remind everybody that these are all pretty much oral therapies. So these are really good for, maintenance treatments. So despite all of this, about 5 to 10% of the patients don't respond to any of these therapies. They have either intolerable side effects from these long-term therapies, and these are the patients we consider as having refractory myasthenia. They harbor significant disability and are often subject to multiple immunotherapies, in addition to using IVIG and PLEX as maintenance therapy. So these patients carry a really high morbidity and mortality and are subject to frequent hospitalizations, ICU visits, and are really high risk for respiratory failure. And a US-based claims study reported that this patient population in myasthenia is 3 times more likely to be hospitalized than the overall general myasthenia population. So as you can imagine, there's this big gap of where we can improve and kind of affect more patients. And so these novel therapies are sort of guided towards specifically myasthenia rather than generalized immunosuppression. So we're going to start by looking at complement. Complement, you guys are all familiar with the complement cascade. So the role of the complement in myasthenia is that when they did some antibody co-localization and immunofluorescence studies, they found that there's presence of IgG, C3, and MAC deposition at the neuromuscular junction. And that was associated with degradation of the postsynaptic membrane, debris in the synaptic space, loss of the receptors at the end plate, and then reduction of the miniature end plate potentials. So the cascade, the complement cascade, plays a pretty important role in fighting against infections and by recognizing and eliminating microorganisms, and also by the removal of immune complexes or dead and modified cells. So there are 3 distinct pathways, but I'm just going to go over the classical, which is the one that tends to be activated in the acetylcholine positive myasthenia patients. So just a quick overview. Here we have the C1q that binds to autoantibody and receptor complex and becomes activated. And this activates the C3 convertase, which further down is a protease that cleaves into C3a and C3b. And then C3b combines with C4b2a and forms C5 convertase. And then the role of C5 convertase, again, is to split into 5a and 5b. And then 5b is the culprit that ends up recruiting 6, 7, 8, and multiple 9s to form the MAC, which is the membrane attack complex. And what this does is it's a lipophilic protein that inserts into the cell membrane and forms a pore that leads to eventual cell death and cell lysis. The other two pathways were not felt to be overutilized in the myasthenia pathology. Receptor positive myasthenia pathology. So this figure just shows the neuromuscular junction as a review. We have the motor neuron that divides into these terminal branches that innervate the muscle fiber. And at the presynaptic nerve terminal, which is up here, there are numerous vesicles that store acetylcholine, and there's a voltage-gated calcium channel. And when this channel is activated after action potential, it opens up, allows calcium to come in, and then acetylcholine is released into the synaptic space. And then on the other end is the motor end plate, which has these deep junctional folds that are rich in acetylcholine receptors and also sodium channels. And so in this receptor positive myasthenia, it's thought that these antibodies bind to the epitopes of the receptor and block the synaptic transmission. And this accelerates the normal receptor to be internalized and turned over. And it also activates the complement cascade. And so the complement activation is what really damages the postsynaptic membrane at the neuromuscular junction, which is what reduces the overall surface area and the number of acetylcholine and sodium channels at the end plate. And then this results in abnormal transmission and then downstream the muscle weakness that we see. So the complement cascade is controlled by various regulatory proteins that prevent complement from being activated all the time or on host cells. And even though there are three major classes of these proteins, we're going to talk mostly about the regulatory proteins that attach to the host surface. So these include CD55 or DAF and CD59. So CD55 or DAF is short for decay accelerating factor. So this accelerates the decay of C3 and C5 convertase, which pretty much inhibits the downstream effects of the MAC formation and complement activation. And then CD59 is also called protectin, which is found on the surface of skeletal muscles. And this opposes the MAC formation by directly binding C8 and prevents C9 from binding and then the MAC molecule from being formed. So preventing the cleavage of C5 was felt to be a pretty attractive target for stopping complement cascade, because once C5 is cleaved into C5a and b, the A component promotes the pro-inflammatory and pro-thrombotic events, whereas C5b is what's involved in the MAC formation. And so blocking the complement at that C5 level, it doesn't really impede with the immunoprotective qualities of the cascade, but rather prevents the regulatory or the downstream activation of the complement. All right. So we'll start with Eculizumab, which is a humanized monoclonal antibody, which binds to C5 and prevents it from being cleaved. It's been long approved for PNH, and a phase 2 study back in 2013 showed that it was effective and safe in patients with refractory receptor positive generalized myasthenia. But this was a pretty small study, and only 6 out of 7 patients, so about 87%, showed clinically meaningful improvements and met the primary endpoint. But 4 out of 7 patients in the placebo group also met the primary endpoint. And then there was a decrease in the QMG score that was observed as early as 1 week after giving this medication, and this was maintained throughout the period of the treatment. So the REGAIN trial, which is a phase 3 trial that resulted in 2017, this was a much bigger study. It had 62 patients in the treatment group, and 63 in the placebo group. And these patients actually had a unique eligibility criteria in that they were all severe, they all had forms of severe disease, which was qualified by having an MG-ADL score of greater than 6 or a classification of 2 to 4 disease. And so the primary outcome here was not met. because they were looking at an improvement in the MG-ADL score from baseline to 26 weeks. However, there were several secondary outcomes that were met, and these included improvement in the QMG, the MG-ADL score, MGC, and MG quality of life score. All of these showed improvement without immunosuppression as a covariant. And it also showed that there was a reduction in the exacerbation rate in the patients that were in the treatment group. I just wanted to show, so again, just from their original papers, the MG-ADL in the treatment group versus placebo group, there was a significant improvement, and then same with the QMG scores. And so ultimately, this led to FDA approval of Eculizumab for receptor-positive generalized myasthenia in 2017. So Eculizumab is now considered acceptable treatment for patients that kind of mirror the patients in the clinical study. So patients that have moderate to severe receptor-positive generalized myasthenia, who also find inadequate benefit or are not able to tolerate side effects of two immunosuppressive or disease-modifying therapies. And then these patients are also maintained on IVIG and Plex as a failure of benefit from traditional immunosuppression. And Eculizumab has a rapid onset of benefit and may be considered as a good treatment to bridge therapies in the setting of maybe getting a post-thymectomy, or even when you're starting one of the older immunosuppressive therapies that take 6 to 12 months. It's considered generally safe, well tolerated, and most common side effects are headache and nasopharyngitis. It does pose a risk for Neisseria meningitidis and other encapsulated bacteria. So it's recommended that when we start this treatment, that we vaccinate for meningitis at least 2 weeks before starting treatment. And it's typically dosed IV weekly for the first 5 weeks, and then every 2 weeks after that. So ravulizumab, just like Eculizumab, also targets C5 and deposits it for degradation intracellularly, but it's actually a little bit longer acting than Eculizumab and was built to be a little more stable. So it's currently approved for treatments in PNH and atypical HUS, and it's administered IV at an interval of every 8 weeks, and typically reduces the burden of coming in every 2 weeks for Eculizumab. So it's a little more favorable. The phase 3 trial for this drug, called Champion Myasthenia, met both the primary and secondary outcomes. It showed that there was a statistical significant improvement in MG-ADL and QMG scores over the course of 26 weeks. And this ultimately led to the approval of ravulizumab, or Ultomiris, in April of last year, for receptor-positive generalized myasthenia. Then we have Zilucoplan, which is a small peptide that binds to C5, and it's got high affinity and specificity for C5, and it again prevents it from being cleaved into 5A and 5B. And this binds specifically to the 5B domain, so even downstream, there's no potential way for C6 to join in and cause the formation of MAC. It's also administered subcutaneously, and a phase 2 study with this drug in myasthenia resulted in 2020, and they chose 44 patients with receptor-positive generalized myasthenia, and they tried to record the QMG scores, patients that had the receptor-positive myasthenia with scores of at least 20, so again, pretty severe disease. And their primary outcome was the change of this QMG score from baseline to 12 weeks, which was met. So here you can see that patients that were on Zilucoplan showed a rapid and statistically significant statistically significant and clinically meaningful difference compared to the placebo group in bringing down the IgG. And the secondary outcome was also the clinical improvement in these various scores of MG-ADL, QMG, MGC. And then the phase 3 trial for this, with the same kind of population, similarly showed really great outcomes. So currently the drug is pending FDA approval for this population. I'm going to take a quick break here and see if anybody has any questions regarding complement, regarding myasthenia, its presentation, its pathophysiology.
Dr. Gandhi, there's some of the treatments that target a different part of the C5 branch that's less infectious promoting, is that correct?
One of them was the Zilucoplan, which was just attracting, or it had high affinity for the C5b component, and so that prevents that downstream mechanism. Yeah. All right, so I'll move on to neonatal Fc receptors. So neonatal Fc receptors have a pretty central role in homeostasis of IgG. In early life, these receptors mediate transfer of humoral immunity from mother to fetus. And in adults, these Fc receptors are found on endothelial cells. They bind to IgG and they prevent it from being degraded in a lysosome. So they are pretty much effectively recycling IgG, and they result in increasing the half-life of IgG compared to other Ig isotypes. So here you can see that IgG binds to the FcRn receptor, and the IgG that's bound to the FcRn receptor is recycled back into the circulation, whereas those that are not bound to the the FcRn receptor are degraded in the lysosome. So in myasthenia, inhibition of this receptor is thought to maybe accelerate these pathogenic antibodies from being degraded and not being recycled. And so that's sort of the mechanism that we were aiming for here. And you could see that if we treat, if we bind FcRn receptor with a different antibody, then all of the pathogenic acetylcholine receptor antibodies are likely to be degraded. So the first in human study by back in 2018 had 62 healthy volunteers who received a single dose of this medication, FcRn. And the objective was to just, again, look at phase 1, safety, tolerability, pharmacodynamics, kinetics. And in the single subject dose, there was a rapid, sustained, and dose-dependent reduction in IgG levels of approximately 50% when compared to the placebo group. And so here you can see placebo in the dark line, and the colored lines are the single doses with variable, single dose of variable amounts. And it's important to note that this 50% decline was seen mostly in IgG1, but other isotypes, IgG 2, 3, 4, those were not really significantly reduced. And then FcRn didn't seem to have a relevant decrease in IgA or IgM. Similarly, those that received multiple doses of FcRn, the level of IG1 reduced greatly compared to the single infusion by approximately 75%. And so again, this is our placebo in black, and these are the 3 doses that were tried with multiple infusions. There were a few mild adverse events that were self-limiting, and these were also reported in the placebo group. And there was no dose-limiting toxicity that was observed. Overall, it was felt to be safe, specific, and showed a significant decrease in the serum IgG levels. So the phase 2 study for this drug, FcRn, they selected patients who were on stable standard of care for myasthenia and received 4 doses over the course of 3-week period of either FcRn or placebo. And the primary outcome here was safety tolerability, which was met. The secondary outcome, which was really interesting, was efficacy. So here they showed that a total serum IgG reduction of about 40% compared to baseline in the first week was achieved. And then there was a further decrease down to 70% with subsequent doses. And this decrease remained, the IgG numbers remained reduced for approximately 3 weeks. What they also found is that there was a 40 to 70% reduction, specifically in the acetylcholine receptor antibodies, as early as 15 days. And 15 days after the first infusion, And then the reduced levels of this antibody were sustained for 29 days after that first infusion, and they gradually approached baseline at about 8 weeks after the last dose. So the phase 3 trial in FcRn called the ADAPT trial, it showed rapid, long-lasting improvement in all of these functional scales. Each of these showed significant improvement, and that's seen by the negative score down here, as early as 7 days after the first infusion. So this led to FDA approval of FcRn or Vyvgart in December of 2021. And this medication is administered IV, 10 mg per kg once weekly for 4 weeks. And interestingly enough, the redosing for this medication is actually based on clinical presentation. So in some people, this medication may work really effectively and you may be symptom-free for the subsequent 4 weeks versus others for subsequent 8 weeks. And so they recommend redosing based on the reemergence of myasthenia symptoms. So there are 4 of these FcRn antagonists that are in clinical trial or just completed. And 2 of them, FcRn and Nipocalimab, are both IV formulations. And then Rosanolixizumab, it's a mouthful, and RVT-140, both of those are subcutaneous formulations. So we just discussed FcRn, which is currently approved for myasthenia. And then Rosanolixizumab is actually targeted towards IgG4. So if you all remember, myasthenia with acetylcholine receptor positive antibodies, it's actually driven by IgG1 and 3. So this, we were thinking, is most likely going to be helpful in those patients that are MuSK positive, because MuSK antibodies tend to be IgG4. And so ultimately, I like to think of this whole category of treatment as, working in a mechanism that kind of parallels plasma exchange. It removes accelerates the depletion of these IgG antibodies, and it's actually a little bit safer, a little easier to get than plasma exchange. So this was an exciting development in our field. All right, and last, we'll just talk about B cells. So I just wanted to remind everybody that in the patients that had myasthenia with thymus involvement, their thymic tissue had shown there were increased number of B cells, pro-inflammatory cytokines, and then significantly increased antibodies in the thymic tissue. But in those patients that didn't have thymic hyperplasia, there were antibody-producing B cells in the peripheral circulation, in the lymph nodes, and in the bone marrow that were thought to be the culprits that made the acetylcholine receptor antibody production. So for this reason, B cells are a pretty good target to, reach the patients that might be having myasthenia that's not coming from thymic etiologies. So here, myasthenia is a predominantly B cell mediated disease. However, there are T cell, B cell interactions, and then B cell related factors that play a pretty key role in production of the antibody. And so B cells that interact with T cells called follicular helper cells here. And these activate and facilitate the B cell to be differentiated and to start producing antibodies. So that's a potential target. Then we have short-lived antibody secreting B cells called plasmablasts. And these are the ones that express CD20 on its surface and are responsible for the production of MuSK antibodies. So this is the reason why MuSK myasthenia typically responds well to treatments that are CD20 geared. But they don't seem to have the same degree of success in patients that have acetylcholine receptor antibodies, because a majority of those antibodies are actually produced in the B cells that lie in the bone marrow. So CD20 does have some degree of role in how B cells are regulated. So it's still a decent target for receptor positive myasthenic patients. And then next, the treatment towards plasma cells, these are that are long-lived and short-lived, that lie inside the bone marrow. This could be a pretty significant target as well, because in receptor positive myasthenia, it's felt that these are the cells that secrete the antibody production. And then lastly, an obvious target is the B cell activating factor, or BAFF, which is a cytokine that binds to B cells and promotes survival, differentiation, and downstream helps the B cells secrete antibodies. So the follicular T helper cells that we talked about, these are found to be increased in thymus and peripheral circulation of myasthenic patients. And this investigational drug called Isocalumab binds to CD40 on the B cells, effectively blocking its interaction with CD40 ligand, which is on the activated T cells. So this is an investigational drug. It's a human IgG1 anti-CD40 monoclonal antibody that inhibits B cell activation via T cells, prevents the germinal center formation and then downstream antibody production without depleting the number of B cells. So the results for this study are not published yet, and I'll keep a lookout for that. Then we have Rituxan, which is a monoclonal antibody against CD20. This regulates the early steps of the cell cycle initiation, activation, and differentiation of B cells. And in a 2017 study, Rituxan showed to be efficacious in patients that had anti-musk myasthenia. They found 58% of patients treated with Rituxan reached the primary outcome compared to 16% on the control. And only 29% of the patients with Rituxan were taking prednisone compared to 74% of the controls at the end of the study. So here I have a little visual of something called MG status and treatment intensity levels, where a level of less than or equal to 2 is defined as a favorable outcome. And so here we saw that at baseline, the patient populations, both control and treatment, they had no patients that had an MG STI of 0. And at their last visit, the study showed that there was a significant number of Rituxan treated patients that had an MG STI of 2 or less compared to the control group. So in 2021, the BEAT MG trial, which is a phase 2 trial for Rituxan in the acetylcholine population, receptor positive myasthenia population, resulted. And they had hypothesized that Rituxan would improve the outcome by at least 30% when compared to placebo. But the primary outcome was achieved in 60% of those that were treated with Rituxan and 56% of the patients that were on placebo. So this wasn't a significant difference. They were looking to see the percentage that achieved greater than 75% reduction in daily prednisone dose prior to the 52-week trial period, as well as concurrent clinical improvement in the patient's MGC score. There were no safety issues that were identified, and there was really no difference between the treatment and the outcome and the placebo group. So this trial concluded that Rituxan is safe, but not likely to reduce the use of steroid by an absolute difference of 30% in 1 year in the receptor positive myasthenia population. And a phase 3 trial studied a slightly different outcome. This trial used Rituxan for new onset generalized myasthenia and looked for minimal disease manifestation with low dose prednisone and the need for, or the lack of the need for rescue treatment. So the RenoMax trial found that a single dose of 500 milligrams of Rituxan was associated with a greater probability of minimal myasthenia manifestation and reduced need of rescue medications compared with placebo. However, this was a pretty small trial and the long-term benefits are not yet studied. So Rituxan is a relatively safe and well-tolerated drug. There are 2 dosing regimens that we can follow, and it's administered IV via infusion, often given with pre-medication. And some of the side effects, they're rare fatal side effects that are related to the infusion, but most of the side effects are pretty minor, including headache, nausea, diarrhea. Prior to starting treatment with Rituxan, I like to screen for Hep B, Hep C, and TB. And then while patients are on it, I monitor their cell counts, and then we use CD19 and 20 as a guide to redosing rather than correlating with relapse. And it's important to remember that routine vaccinations should be given 4 weeks prior to the starting of Rituxan. We try to avoid live vaccines here. So Belimumab is a humanized monoclonal antibody against B-cell activating factor, or BAFF. It's already approved in adults with antibody-positive systemic lupus. BAFF levels were found to be elevated in patients, in myasthenic patients, and this was likely contributing to abnormal B-cell proliferation, prolonged survival, and then the antibody production. So antibodies against BAFF are felt to be a potential target for this disease. So a recent phase 2 trial showed similar safety profile as in the lupus population. They looked at general myasthenic patients who remained symptomatic despite standard of care treatment. And what they found is that the study failed to meet the endpoint of meaningful change in the QMG score from baseline to 24 weeks, as you can see here. And then with regards to the MGC and MGADL scoring, there was also no change between placebo and the treatment groups. Keep in mind some limitations of this study is that it was small and it was a short study because in the lupus population, it was felt that antibodies were thought to, it was thought that 1 to 2 years of treatment with Belimumab was showed benefit. So again, we just studied the medication in such a small time frame that we might not have seen any significant improvement. All right, and lastly, bortezomib. This is a treatment that's currently approved for multiple myeloma and mantle cell lymphoma. It's a small molecule pan-proteasome inhibitor that depletes the short and long-lived plasma cells that were in the bone marrow, if you recall. So a study in 2014 was where they applied bortezomib to cultured thymic tissue of myasthenic patients. And this showed that there was a depletion in the long-lived plasma cells and that it consistently halted the production of autoantibodies against acetylcholine receptor. It also reduced the general IgG production. Sorry, I'm a little slow on my clicking. So there's limited clinical experience with bortezomib in myasthenia. And there's currently a phase 2 trial that's being done in Germany, but it's actually utilizing lupus, RA, and myasthenia patients because, again, there's a sort of a dearth of patients there. So just to kind of wrap things up here, there are 3 more novel categories of treatments that we're using to treat myasthenia with this receptor positive myasthenia. And this is just to fill that deficit of, those 10 to 15% of patients that remain refractory, or a number of patients that may not tolerate the current therapies. These treatments are not really intended to replace any of the existing therapies, but rather to add or to bridge to longstanding immunosuppression. And as more of these are approved, we anticipate that there are going to be challenges in access, in cost, in guidelines, and availability of these treatments. I just have a quick summary of sort of how I treat myasthenia, sort of medications that are fast acting, show benefit, and how quickly they can be initiated. And so just in case anybody was interested.